We've spent the last 30 minutes building your clinical toolkit with motivational interviewing, CBT, IPT, and supportive therapy. You now have real skills for doing this work. But there's a piece that doesn't get taught in most programs, and it costs providers and their patients. That's billing. Specifically, how do you translate what you just did in that room into a CPT code that gets reimbursed, stays compliant, and actually reflects the care you delivered? Everything in this segment is grounded in the Medicare local coverage article governing psychiatry and psychology services. It was revised January 1st, 2026, so this is current today and may change tomorrow, so please verify it when you start practicing. There are over 25 CPT and HCPCS codes covered under this article, and over 800 ICD-10 diagnoses that support medical necessity. You don't need to memorize, but remember to check your state's scope of practice. Who can build these codes? Before we touch a single psych code, we have to talk about scope. This is the foundational compliance question, and one that NPs in particular often haven't been explicitly taught. The rule is this: psychiatric CPT codes may be used by physicians and non-physicians, including nurse practitioners, when the services performed are within the scope of their state license and their clinical practice and education. Both criteria must be met, not one, but both. For FNPs in primary care, this means you can bill psychiatric codes for depression and anxiety management, ADHD, insomnia, and conditions you are trained to manage. Medication management for psychiatric conditions flows through your E and M codes, which we'll talk about. E and M stands for evaluation and management. If you're conducting a brief structured behavioral intervention during a visit, that may qualify for a psychiatric CPT code, as long as it's within your training and included in your NP protocol. What you cannot do is bill codes that require PMHNP level training if that training isn't in your background. For example, if you haven't been trained in structured psychotherapy, billing a standalone psychotherapy code creates exposure. For PMHNPs, the scope is broader. You have the full range of psychiatric codes within your state license. And critically, 90792, the Psychiatric Diagnostic Evaluation with Medical Services. This is your initial evaluation code when prescribing psych meds. 90791 is the code for the initial psych evaluation without prescribing meds. We'll come back to this distinction. One more thing for PMHNPs specifically. Your authority to provide psychotherapy varies by state. Some states explicitly authorize it, others are silent or restrictive. Florida is permissive, but that does not automatically extend to other states if you're practicing via telehealth across state lines. Always consult your state board before assuming. The warning bar at the bottom of this slide is not a formality. Billing outside your scope is a compliance risk. It can trigger audits, recoupment, and in serious cases has licensing consequences. When in doubt, verify. Now here's where most billing education goes wrong. It starts with a list of codes. We're not doing that. We're starting with the logic because once you understand the 5 categories, the codes place themselves. Category 1, diagnostic evaluation. These are your 90791 and 90792 codes. This is where you start with a new patient, or restart after a significant break or change in status. Category 2, individual psychotherapy. Codes 90832, 90834, and 90837. These are standalone psychotherapy codes, time-based, used when the focus of the visit is the therapy itself, with no E and M component. Category 3, E and M plus psychotherapy. This is the add-on category, 90833, 90836, and 90838. These are used when you do both a medical evaluation and a psychotherapy session in the same visit. They are add-ons to an E and M code, not standalone codes. Category 4, crisis psychotherapy, 90839 and 90840. These stand together, meaning they cannot be combined with regular psychotherapy codes on the same date, and that's a rule many get wrong in practice and it gets kicked back. Category 5, interactive complexity, code 90785. This is an add-on, never billed alone, for specific communication difficulties during a psychiatric procedure, particularly relevant in primary care. Notice what's happening here. Each category answers a different clinical question. Was this a first visit? Category 1. Was the whole visit therapy? Category 2. Did I do both medicine and therapy? Category 3. Was this a crisis? Category 4. Was there a communication complicating factor? Category 5. That's the map. Let's go deeper on each one. Before we move into the psychotherapy codes, we need to stop here because this is the first billing decision a PMHNP makes with every new patient, and it is one of the most commonly miscoded services in psychiatric practice. There are 2 codes for the psychiatric diagnostic evaluation, 90791 and 90792. They look almost identical. The difference is 3 words. 90792 says with medical services. As a PMHNP in a treatment role, 90792 is your code. This is your default for every initial psychiatric evaluation. Here is what with medical services actually means in practice. Prescribing authority is exercised, or medication decision-making occurs, even if you defer starting the medication that day. You assessed medical factors relevant to psychiatric treatment, current medications, contraindications, cardiac history, renal and hepatic function where relevant, substance use. You ordered or planned labs relevant to medication management. Now here's the question I get. What if I did the evaluation but I didn't prescribe? Maybe you wanted labs back first. Maybe the patient needed more time to decide or you are waiting on a court order. Maybe you determined at the end of the visit that medication wasn't the right first step. The answer is 90792 still applies, as long as medical decision-making occurred. Document your medication considerations, document your clinical reasoning about why you're deferring, document the medical factors you assessed. That narrative is what justifies 90792 on review. Now, that said, there are circumstances where a PMHNP would appropriately bill 90791. And that's when you are functioning in a purely evaluative role where prescribing is explicitly not part of the engagement. Forensic evaluation, you've been retained to assess competency, criminal responsibility, or fitness for duty. You are not the treating provider, you are not prescribing. School-based assessment, conducting a diagnostic evaluation where the scope is limited to diagnosis and educational recommendations, no prescribing authority exercised. An independent medical examination retained by an employer or insurer, a disability evaluation for SSA or the VA. In all of these, the common thread is no treatment relationship, no prescribing authority exercised, evaluation is the entire scope. That is 90791 territory, but that is not what you typically do. In standard clinical practice as a treating PMHNP with prescriptive authority, 90792 is your code. One more thing, 90792 is used once at the onset of treatment. It is not an annual code. After the initial evaluation, your ongoing visits move into the psychotherapy or E&M code set. The LCD gives you 4 specific circumstances where you can repeat it. A break in treatment of approximately 6 months, admission to inpatient psychiatric status, a significant acute change in mental status, or a need for a second opinion or diagnostic clarification. Outside of those 4, you cannot rebill a diagnostic evaluation for an established patient you have been seeing continuously. The standalone psychotherapy codes are time-based, and the time thresholds matter. 90832 is your 30-minute code, but the actual face-to-face time window is 16 to 37 minutes. 90834 is your 45-minute code, covering 38 to 52 minutes of face-to-face time. And 90837 is your 60-minute code, 53 minutes or more. 2 words in that last sentence are doing a lot of work. Face-to-face. The time that counts toward these codes is time spent directly with the patient. Not documentation time, not coordination time, not the 5 minutes you spent reviewing the chart before walking in. Face-to-face time only. Use these codes when the focus of the visit is individual psychotherapy. If you briefly discuss a patient's anxiety during a diabetes visit and prescribe a medication, that is not a psychotherapy visit. If you conduct a structured 45-minute CBT session for generalized anxiety disorder, that is. The documentation requirement is straightforward but critical. You must document the time spent face-to-face and the medical necessity for the service. Not assumed, documented. One more rule: if a session runs longer than 90 minutes, reimbursement requires documented medical necessity for the extended time. That's not a common situation in primary care, but it's worth knowing. This slide is the one that trips up the most providers, including experienced ones. Let's slow down here. You can bill a medical evaluation and a psychotherapy session on the same date of service. That's legitimate, it's billable, and for PMHNPs especially, it reflects what actually happens in a med management plus therapy visit. The key is how you do it. The add-on codes are 90833, 90836, and 90838. Each represents 30, 45, or 60 minutes of psychotherapy added to an E and M code. Here's the critical rule, and I want you to say it back to yourself. The time you spend on E and M activities cannot count toward the psychotherapy time. They are two separate identifiable services, separate documentation, separate medical necessity. The time cannot overlap. What does that look like in practice? You review labs, adjust medications, update the problem list. That's your E and M. You then conduct a structured 35-minute depression-focused therapy session. That's your psychotherapy. Two distinct services, documented distinctly. Now, the common errors. First, do not use time as the basis for E and M code selection when you're also billing a psychotherapy add-on. Your E and M level is determined by medical decision-making, not by total visit time. Second, prolonged service codes may not be reported alongside the psychotherapy add-on codes. Third, both services must be significant and separately identifiable. You cannot do 5 minutes of medication review and call it an E and M. That won't hold up to scrutiny or audit. One reassurance, though, is that a separate diagnosis is not required. You can have the same ICD-10 code driving both the E and M and the psychotherapy, as long as both services are documented as distinct. And psychotherapy codes are payable in all settings: inpatient, outpatient, office, or telehealth. The site of service is not a barrier. Let's bring this to life with 3 scenarios that represent what actually happens in primary care. Scenario A, E and M only. Your patient comes in with hypertension. You notice she seems stressed. You ask briefly about anxiety, prescribe lisinopril, and suggest she reduce stress. You bill the E and M code only. Why? Because the mental health piece was incidental. It wasn't the focus of a structured, documented intervention. You didn't conduct psychotherapy. You noticed and responded, but that response was part of your E and M counseling, not a separate psychiatric service. Scenario B, E and M plus psychotherapy. Your patient has type 2 diabetes and major depressive disorder. In the same visit, you address her glucose management, reviewing labs, adjusting metformin, updating her problem list. That's your E and M. You then conduct a structured 30-minute CBT-based behavioral intervention for her depression, which you document separately with its own clinical narrative. That's 90833 as the add-on. This is appropriate, this is billable, and this is what integrated care actually looks like when documented correctly. Scenario C, psychotherapy only, established patient. The entire 45-minute visit is focused on generalized anxiety disorder using motivational interviewing and CBT techniques. No new medical issues, no medication adjustments. You bill 90834 alone. The question you should ask yourself at every visit is this: is the mental health intervention the focus of a structured, documented service, or is it incidental to the medical visit? That question determines your code selection. Interactive complexity is an add-on code, 90785, that many providers either don't know about or avoid because they're uncertain when it applies. In primary care, it applies more often than you'd think. Here's the core definition from the Local Coverage Determination, LCD. It's for specific communication difficulties during a psychiatric procedure, and 3 categories of patients typically qualify. First, minors or adults with legal guardians. If you're providing a psychiatric service to a child or to an adult whose guardian is present and participating, you have a qualifier. Second, adults who request others to be involved. If an adult patient brings a family member or requests an interpreter to participate in the visit, not just translate in the waiting room, but actively participate, that qualifies. Third, Patients involved with third parties, child welfare agencies, probation officers, schools. If those systems are involved and relevant to the visit, that's your qualifier. But qualifying patient population is only half the equation. You also need documentation of at least one specific communication difficulty. The LCD gives you 4 to choose from: maladaptive communication, high anxiety, repeated questions, disagreement that complicates delivering care, caregiver emotions or behavior that interfere with the treatment plan, disclosure of a sentinel event, abuse, neglect, where you've initiated a mandated report and begun discussing it with the patient and others in the visit, or use of an interpreter, translator, or play equipment to overcome significant language barriers. The last one is particularly relevant in South Florida primary care settings where language access is a daily reality. If you have a patient with limited English proficiency, a participating interpreter, and you're conducting a psychiatric service, that's 90785. Okay, now the hard stops. You cannot add 90785 to crisis codes 90839 or 90840, and you cannot add it to an E&M code when no psychotherapy is also being reported that day. It must attach to a qualifying psychiatric service. Crisis codes stand alone. That's the most important thing to remember about 90839 and 90840, and it's the rule that gets violated most often. 90839 covers the first 60 minutes of psychotherapy for crisis, reported by itself, covering the initial intervention. 90840 is the add-on for each additional 30 minutes beyond that, used with 90839 only, when the crisis intervention requires extended time. You will encounter crisis situations in primary care. A patient discloses active suicidal ideation during what you thought was a routine follow-up. A patient arrives in acute psychiatric distress. These situations happen, and when they do, you need to know your billing options in advance, not in the middle of managing the crisis. The rules are absolute. Do not combine 90839 or 90840 with regular psychotherapy codes on the same date. Do not combine them with 90791, 90792, or 90785 on the same date because these codes stand alone. There's an update effective January 1st, 2024 that you need to know. HCPCS codes G0017 and G0018 are now used instead of 90839 and 90840 for non-facility, non-office places of service. So if you're delivering crisis psychotherapy in a patient's home or via a community-based program that is not a facility and not your office, you use the G codes. If you're in the office or an applicable facility setting, hospital, ED, you continue with 90839 and 90840. For documentation, you need to capture the precipitating event, the patient's mental status at the time, the specific intervention you provided, the time spent, and the medical necessity for crisis-level care, as distinct from routine psychotherapy. That clinical narrative is what protects you. Let's put all of this together. Let's read through the scenario. Maria is a 42-year-old established patient with type 2 diabetes and a recent diagnosis of MDD. She presents today with her teenage daughter, who is serving as interpreter. Maria has limited English proficiency. You spend 20 minutes addressing glucose management and adjusting metformin. You then spend an additional 35 minutes conducting structured CBT-based therapy focused on her depression and functional impairment. The daughter's presence is necessary for communication and creates some complexity in managing the session. What do you bill? Look at the options. Option A, 90837 alone, would mean you're billing a standalone 60-minute psychotherapy code, but the 20-minute E&M component was real and distinct. You can't ignore it, and you also can't fold it into the therapy time. So A is wrong. Option B, E&M plus 90836 would mean billing the 45-minute psychotherapy add-on, but the psychotherapy time was 35 minutes, which falls in the 30-minute code range. That maps to 90833, not 90836. So B overcounts the therapy time. This is wrong. Let's look at option D. 90839 is the crisis code. Maria is not in crisis. She's distressed, she has MDD, but distress does not equal crisis. This is a common misconception. Crisis codes require crisis-level clinical presentation. So this one is wrong too. Option C is correct. E and M for the glucose management and metformin adjustment, plus 90833, the 30-minute psychotherapy add-on, because 35 minutes of face-to-face psychotherapy maps to the 30-minute code, plus 90785, interactive complexity, because the daughter is serving as interpreter and is actively participating in the psychiatric service, which is exactly what the LCD describes as a qualifying communication factor. The times don't overlap. The services are separately identifiable. The documentation supports each component. That's a clean, defensible claim. 6 things I want you to leave with. 1. Scope first. Every time, before you select a code, ask yourself, is this service within my state license and within my clinical education? You need to meet both criteria, not one. When in doubt, your State Board of Nursing is your resource. 2. 90791 versus 90792. If you're a PMHNP and you're doing an initial psychiatric evaluation that includes medical services, prescribing, medical decision-making, you bill 90792. We've discussed when to use 90791. 3. E and M and psychotherapy on the same day is legitimate and billable, but the time cannot overlap, and both services must be documented separately with independent medical necessity. This is not a technicality. It is the structural requirement for the claim to hold. 4. Interactive complexity is an add-on you're probably underusing, in primary care especially, with minors, with limited English proficiency patients, with families involved in care. 90785 often applies. Document the specific communication difficulty, not just the qualifying patient category. 5. Crisis codes stand alone from the regular psychotherapy code set. 90839 and 90840 go together as a pair. 90839 opens the crisis intervention, and 90840 is added for each additional 30 minutes beyond that first hour when clinically necessary. What they cannot do is mix with the routine psychotherapy codes. So within the crisis code family, 90839 and 90840 work together. Outside that family, they stand alone. 6. And this is the one that ties everything together. Documentation is the difference between a clean claim and an audit. The code you select must be supported by what is written in the chart. For psychotherapy, document time, medical necessity, the nature of the service. These must be in the record, not assumed, not implied. If it's not documented for billing purposes, it didn't happen. I hope this lecture is helpful. As you move forward in your practice, remember that our role is not just to diagnose and prescribe, but to engage, understand, and guide patients through change. The most impactful moments in care are often not the medications we choose, but the conversations we have, how we ask, how we listen, and how we help patients make meaning of their experiences. Use these approaches not as rigid frameworks, but as tools to think more clearly, respond more intentionally, and meet patients where they are. Ask questions that uncover meaning, not just symptoms, and trust that even brief, thoughtful interactions can make a lasting difference.